Well, we're moving right along here. We're in chapter 19, which deals with documentation. And what we hope to get accomplished in this particular chapter is to describe the potential consequences of illegible, incomplete, inaccurate documentation. Explain the role and the importance of documentation pertaining to the following: the continuity of patient care, quality management, data collection, research, billing and reimbursement. Explain how to document information received from bystanders and other third-party resources. Explain how to document scene assessment findings, and discuss the importance of documenting pertinent positive and pertinent negative findings. Explain the importance of using medical terminology appropriately. Discuss the importance of using only locally approved medical abbreviations, and discuss the importance of a timely report writing and submission of that report. To be familiar with different methods used to document, including the handwritten patient care report, as well as the electronic computer-based patient care report and dictation. Discuss the importance of documenting a consistent narrative style identified by local protocol. Describe differences between subjective, objective documentation elements. Describe special considerations for documentation, like patient refusal of care and transport. Describe special considerations for documentation, including multiple casualty incidents. Evaluate completed pre-hospital care reports for completeness, thoroughness, accuracy, spelling, grammar, the use of medical terminology, and the use of approved abbreviations. Now, we've touched briefly in the communications chapter about the patient care report. And the patient care report needs to be completed after the call is done. And the sooner the better. If you wait a while to complete the patient care report, really important information can be lost. The patient care report outlines everything that you saw and everything that you did. It's a record of the event that ends up in the patient medical record and is submissible in court as a legal document. So it must be complete, it must be thorough, it must be accurate and legible. With electronic patient care reports, legibility has not been an issue, but spelling still is an issue, even with spell check. The functions of your good documentation have to deal with continuity of care. You're the first set of eyes on this patient. You're the first one to see the patient. You know what their condition is initially, and should their condition deteriorate or change or improve, you're the only one that knows that. And so being able to document that information and pass that along to those who are caring for them in the emergency department is extremely important for continuity of care. Your documentation it's a legal document. It is admissible into court. It is part of the patient medical record, and certainly may be pulled up by medical directors, service directors, lawyers, that sort of stuff that may have questions about a particular scene, as well as your actions in the care that you provided. There's also a legislative piece of this that we don't think much about when writing a patient care report, but certainly patient care information that's being accumulated by multiple services over a broad area can help justify the request for law change, can help increase the potential possibility for grant money or government funding. Research is another function of documentation. Retrospective research, where after the fact we're going to look back on what you did and why you did it, and see if there needs to be any sort of improvement. Quality management. Your medical records are scrutinized, by your service director, by your medical director, by a designee within the organization that is assigned to do medical audits. And, they're going to look at your performance, how you performed on this particular call. And is there anything that you could do better? And if so, make that, known to you. Your documentation is extremely important to billing and reimbursement. Documenting appropriately the number of medications used, as well as any other diagnostics used, increases the level of acuity and therefore increases the payment that you might receive, or the service might receive, for caring for that patient. Here's an example of a patient care report. This certainly is it's a paper care report. Has lots of boxes, lots of check boxes, a space for narrative there in the end. And it's important that, if you use a written patient care report, that you do fill out all the boxes. Not filling out a box tells the reader that that box was not important, or you just are sloppy in the way that you do your documentation. Data elements are so vitally important in research. They're so vitally important in querying data. And NEMSIS, the National EMS Information System, includes 75 different data elements in their patient care report. Now, first name could be a data element. Last name could be a data element. So while 75 data elements seems like a lot of information that you'd have to report to NEMSIS, and not every state reports to NEMSIS. Iowa does, and that's really neat, because we're going to talk briefly here about the NEMSIS Cube and the importance of that organization. The National EMS Information System Organization. There are a handful of states that submit all their patient care reports to that national database. And what that allows me to do with the NEMSIS Cube is to query information that I want to know about, not my competitors, but my area. The information in the NEMSIS Cube does not identify individual services. It identifies regions, that sort of thing. So, the bottom line with the NEMSIS Cube is, if I want to know how many times on Tuesday that a 7-year-old received morphine for a broken arm, I can do that. The ability to query data is just amazing with this NEMSIS Cube. And if you do a Google search for NEMSIS Cube, it'll take you to the website. There are tutorials that will help you identify how to write a query, so that you can determine, regionally, how well you're performing or stacking up against the region. Some identifying data that certainly should be included in all patient care reports includes the patient's name, the address, perhaps the date of birth. I'm not sure on the Social Security number, but certainly the name, address, date of birth. Now, we're going to get information to put in our patient care report from the patient if they're alert, awake, and oriented. And if they're not, you have to question their ability to be a historian. And you may have to get the information then from family members, and if they're not available, from bystanders or law enforcement. It's important that we record where the call was. Did we pick this patient up at their residence? Did we pick him up at a business or a farm or a park or roadway? And then we want to keep track of our times. Times are extremely important. They drive a lot of what we do. Extended on scene times are certainly something that on a national level is being scrutinized. So we need to be able to record the time that we were dispatched, the time that we got on scene, the time that we left the scene, and the time that we got to the hospital. Now, your assessment in your patient care report should include a description of the scene, the patient's chief complaint, any sort of initial findings that you might have discovered in your initial assessment in your primary survey, and then pertinent positive findings and pertinent negative findings are important to document as well. If I have a patient who has chest discomfort, a pertinent positive finding would be, if I believe this to be heart-related, would be pain that radiated to the neck and the jaw and down the left arm. That would be a pertinent positive finding. But I should also document as well, if I have this patient who has chest pain, document that patient denies pain to the jaw or denies radiation of discomfort to the jaw, the neck, and down the left arm. By documenting both pertinent positive and pertinent negative findings, that tells the reader that you've considered those things. If you don't document it, that old adage, if it wasn't documented, it wasn't done, holds true. And then document all your diagnostic findings as well. Your past medical history is something that needs to be on the patient care report as well. That includes allergies, medications, to include over-the-counter meds, any sort of previous diagnosis or previous surgeries pertinent to the chief complaint, previous similar episodes, family medical history, particularly if you're responding to somebody who has heart-related chest discomfort and you're thinking it's a heart attack, do they have any family history of heart disease? Social history is important as well. The history of the present illness includes, the time that the illness came on, what were you doing when it came on, what sort of pain and discomfort are you having, and if you are having pain and discomfort on a 0 to 10 scale, with 0 being no pain and 10 being the worst pain, how would you rate that pain? And then describe it. And it's really important that when we talk about pain discomfort description, that we allow the patient to tell us what the pain or discomfort is like. If I say to them, is it sharp or dull? Well, I've only given them 2 choices. And if their pain is not sharp or not dull, they have to plug in their pain to one of those descriptors, which may not be accurate in describing their discomfort at all. What makes the pain better or worse? That's important to know. And then what treatment was done prior to EMS getting there. You need to also identify your treatment in your patient care report. You need to be really specific. It's not enough to say, well, I gave the patient O's, or I gave him some oxygen. I gave him 6 liters by, non-rebreather, or, 2 liters by nasal cannula. I started a 18 gauge needle in the right forearm and ran normal saline at TKO. Medications, certainly documenting the name of the medication, the dose and the route, all those sort of things. Intubation, documenting the success, that, what did you see that would indicate it's successful, and documenting that, and then bandaging and splinting as well. You need to document your patient's response to the treatment. Did they get better? Did they get worse? Or was there no change? And then document where you're taking the patient, how they're getting there. If you are transferring a patient from one facility to a next, and they go from an inpatient unit to an inpatient unit, when you get on the other end, you certainly need to document the room number, the the name of the facility, what room you left them in, who was in charge of the patient when you left, that you did leave all the patient belongings, particularly if you're transporting things like hearing aids or dentures or those sort of things, because we often get gigged. A patient will get transferred to another facility, and during the transfer, uh, you know, their hearing aids are lost, or their dentures are lost, or their watch is lost, or those sort of things, and it's important that we document what belongings we did leave. It's important to also document the factors that influence your transport decisions. With Iowa's trauma system, if I have a patient who has a critical life threat, then I'm certainly going to move quickly and not spend a lot of time on scene. Where if I have a patient who has an isolated ankle fracture and that's the only thing that's wrong with them, well, that's not a severe life threat. And I certainly may spend a little more time on that scene, establishing an IV and giving them some medications for their discomfort. And then when you drop the patient off, it's really important that you do get a signature from staff at the receiving facility who takes over care of the patient. With the advent of using laptops in order to fill out your run reports, this is a step that's often overlooked. But if you're still using, paper reports, there's no reason that you can't get signature of the person who you drop the patient off with. Medical terminology, we've already had a whole section on this, where the root word is the primary meaning, and then the prefix is added to the beginning and the suffix is added to the end, and depending upon the prefix and suffix, it may change the actual meaning or primary meaning of the word. They make it a noun, a verb, an adjective, whatever. But it's important that when using medical terminology that you use words that you understand and that you know how to say. It'd be totally inappropriate if you're using words that you have no idea what they mean, nor can you pronounce them. It's important that when we use medical abbreviations that they are locally accepted and approved locally. Otherwise, other people are going to read the run report, and if it's written in Jeff hand, where I've put in all kinds of abbreviations that I like to use, but may not necessarily be acceptable in my organization, then that can be a challenge. When we're dealing with errors, it's important to just, if you're doing a written report, to draw a single line through the error and then initialize that line. Whiting something out, scribbling it out to the reader might indicate that you made maybe not necessarily an error in the word, but an error in patient care, and you wanted to hide it by covering up or writing out what you had written. If you've got multiple errors, that's just a sign of unprofessionalism, and while it may happen, just rewrite the report rather than trying to put lines through everything and initial everything. Just start over. Electronic patient care reports, that's something that certainly is more prevalent now, and there aren't many people that still write handwritten reports. It's all done on a computer. And it's important that you use spell check and that you understand, too, the words that you're asking it to spell check. Because spell check is not always right, and hopefully you catch what I intended to do with this particular slide. If I were to spell check the word right, if that's correctly spelled, but it's not the word I should be using, R-I-G-H-T should be the word I should be using. Here's just an example of drawing a line through a single word, drawing a single line through a word that's misspelled or doesn't belong, and then initialing it. As far as timeliness of your documentation, It'd be awesome that when you drop the patient off, if you could leave a run report with the hospital, and many facilities require you to do that. Because again, once you leave, you're the eyes, you're the first set of eyes on that patient. And if a physician has a question about what the patient looked like initially and, during your care, they're not going to know that. They're just going to know what they look like right now. So it'd be really nice if you could complete the run report before you leave the facility. If you get really busy, back-to-back calls, that sort of stuff, many facilities will let you wait about 24 hours, but sometime within 24 hours, that run report has to be written. And the sooner the better, because the sooner you write it, the less details that are lost. Now, if you've got an addendum and you need to add something to a run report that's already been written, you can do that, and it usually is a separate form. You have to identify the reason as to why you're writing the addendum, and then sign and date it when you're done. E-signatures, that's certainly something that are out there as well. Typically the way they handle e-signatures is that, if I log in to this piece of software, then by signing it, then my signature is good by just typing in my name, because it's already tracked the fact that I've signed in, because it knows who I am. Handwritten documentation is part of the documentation process. Not as frequent as it has been, but it's still out there. By far, computer-based documentation is what's being done mainly. Dictation, not really something we see in the emergency arena, but if you do see it, it's in the form of voice recognition software, where instead of me sitting there and typing everything, I just talk into a device that recognizes my voice and then types the words in for me. Now, there are several different formats to document. One of those formats is called Chart. And when you use charting as a way to document, you begin with writing the patient's chief complaint, and then you put in their sampler history, and then you write in everything that you did concerning the assessment and what you found, and then you write your treatment, and then you write your transport decisions. And here's an example of chart, where down below here you can see that they've put in the chief complaint, the history, the assessment, the RX that's considered, and then the transport, or things that occurred during the transport. Trying to get rid of that little thing there. There we go. SOAP is another method of documenting, and SOAP is one that I'm far more familiar with, because that's all we used to use was SOAP to do documentation. SOAP includes recording subjective findings, that's everything the patient tells you, objective findings, everything that you see, and then the assessment of the patient's condition and the plan for treatment and transport. And a third method is just a written narrative. And written narratives are nice because it's storytelling, but they can get quite wordy. They can be redundant, and they're very difficult to extract data from. And here's an example of SOAP, where you can see down there where they've recorded the subjective information, the objective information, and the assessment and plan. Here's an example of just the narrative. And again, the narrative is just storytelling, but oftentimes what we see occur is, if I've got boxes up there where I put vital signs in, and I have boxes up there where I check, I listen to lung sounds, or I did this, that, and the other thing, I wouldn't need to include that in the narrative. But typically most people, when they write a narrative, write everything that they saw, heard, and did. Now, when we're dealing with multiple patients, you need a separate patient care report for each of those patients. and when dealing with refusals, that occurs when the patient does not want to be transported. In order for a patient to refuse treatment, they need to be awake, alert, and oriented, and not under the influence of drugs or alcohol. You have to explain to the patient and document the potential consequences of refusing transport. So if I have a patient who's having heart-related chest discomfort and you get there and do your assessment and they're pale and sweaty and everything looks like they're having a heart attack, and you do a 12-lead ECG and it's an anterior injury, you're thinking, well, I should probably hook this patient up to a monitor. I should probably, give aspirin and nitroglycerin and morphine and those sort of things, but your patient doesn't want anything to do with it. And well, in that particular case, then you need to explain and document the potential consequences of refusing transport. If you think this patient's having a heart attack based on your assessment and they don't want anything to do with you and they don't want to go and receive care and that sort of thing, you need to let them know the consequences of not receiving care. You should offer them alternatives. Your patient refusal chart should include things like call 911 if this happens again, go to your doctor's office, drive yourself to the emergency department, but give them some alternatives rather than just saying you're not needed and leave them there. Your patient refusal form needs to be signed by the patient, by the paramedic, and some sort of witness. And here's an example of a patient refusal form. And this is pretty good because they do isolate some specific issues in some patients that may be a little belligerent, to include head injuries, spinal cord injuries, those sort of things. Cancellations. Sometimes you're en route to the scene and the comm center gets on the radio and says, be advised you're no longer needed. Well, many of us will just keep going to the scene, see what's up, and we may in fact be needed, or we may not. But in situations where you are canceled, you need to document who canceled you. When you're dealing with multiple casualty incidents, using some sort of abbreviated report is perfectly okay. Triage tags, they certainly can be used in multiple incidents, and we have a whole section on triage. So we're not going to spend a lot of time on this. Just do understand that there are triage tags in every one of the ambulances, and depending on the severity of the patient, reds are highest, they're number 1 priority, yellows are number 2, greens are number 3, and then blacks are the deceased. Some other essentials concerning your documentation is that it's got to be objective. Objective information is information that you see. I couldn't put in my run report that the patient fell down the steps unless I watched them do that. If I didn't see them do it, essentially what I'm being told is hearsay. Your documentation needs to be thorough. It needs to be legible. It needs to be timely. There's a certain time frame in which it has to be completed. It has to be error-free and rememberable, because the average lawsuit takes anywhere from 3 to 5 years before you're pulled back into a court of law. And 3 to 5 years from now, are you going to remember the ambulance call? And if not, it's important that you document so that you do, 3 to 5 years from now when you're reading it, it jars your memory. Quality management. Quality management is, continuous quality improvement. The ability to look at where you are right now and based on your performance make changes that ultimately affect outcomes and improve patient care. So your skills are often monitored. They will keep track of your successful IV skills, your successful intubation skills. And a person, while there's no hard and fast rule as to how many of these things you need to do in order to remain competent, it's often set by the agency or the medical director to determine, well, you've got to have 3 intubations a quarter if you're going to continue to intubate. Run reports or trip audits, not all run reports are audited. In many systems, the run reports are audited by a medical director and or director of the department. And they may choose to edit all run reports that you have. And if you have a small volume of run reports, that's probably okay. If you have a larger volume of run reports, or they just really didn't think they needed to do that, then there may be selective monitoring. Oftentimes what we'll do as an example is if we implement a new protocol, then anytime that protocol should have been used, we'll assess to see if it was and what the outcomes were. So in summary, documentation is one of the most important parts of your job. Your report written by your paramedic is commonly the only documentation of the events of the scene and what occurred during transport. So documentation can affect your patient care. Documentation, it's a legal document, so it can be brought into a court of law. It helps define and expand both our scope of practice. They certainly can be used in future calls as a form of education and training, and proper documentation makes sure that your service gets reimbursed properly for your calls. The written report should be timely, it should be complete, accurate, legible, objective, and error-free. When a reader reads it, there should be no question in mind why you treated the patient the way that you did. It should be written in a set format, whether it be chart or SOAP or just a written narrative. And reports can be written by hand, they can be entered in a computer-based system, or they can be completed by dictation. And all interactions in a patient should result in some sort of report, whether it be a written report or just some sort of report. All right, and with that, we are finished with Chapter 19 on communications, on documentation. Chapter 18 was communications, and this is Chapter 19, which is documentation. And so I'm going to end here, and should you have any questions, feel free to look me up at the email address listed there, or give me a call on my cell, 712-320-8220. Thanks so much, and I'll talk to you soon.